But we'll go ahead and get started. My name is Julie Babbage. I'm the Executive Director of the Diabetes Patient Advocacy Coalition, and welcome to the Tennessee Diabetes Advocacy Forum. We are excited to be with you today virtually to discuss the top issues in diabetes advocacy and to talk about how you can become a diabetes advocate. And on the next slide, you'll see the agenda. We'll start with a quick overview of DPAC and who we are, and have a discussion with today's special guest, Senator Briggs. That's really exciting because 77% of registrants for today's event indicated that you have not yet gotten the chance to meet with a lawmaker. So after today, you can say that you have, as Senator Briggs has very graciously offered his time to join us. And then after that, we'll take a look at some of the policies, and that'll take us into the issues themselves. We'll give an overview of our top priorities as an organization, and that will center on affordability and access for people with diabetes. And then we'll transition into the state and federal dynamics for Tennessee politics and how to be a diabetes advocate. Just a couple housekeeping items on the next slide. If you've got questions at any time for us, just know that you can write those in to the chat box and we will answer those as we have time. If you've got questions for a specific panelist, we'll work extra hard to make sure that those are asked aloud, but we'll also be writing in on the back end to answer those questions too. And again, we are recording today's meeting, which we will send out after it concludes. To begin, I mentioned that we're working on behalf of all people with diabetes, and DPAC's mission is solely advocacy. That includes federal work and state work, like here in Tennessee, making meaningful changes in law and also in regulation so that people with diabetes can live long and healthy and productive lives. DPAC started because it was incredibly apparent that lawmakers were not hearing from the patient community when making decisions that impact people with diabetes. And that wasn't because people with diabetes don't care about the decisions. On the contrary, the community, as I'm sure many of us know, is one of the most passionate. It was more a result of how hard it is to keep up with the process and the issues. And so our work is focused on making it easy to advocate for yourself and for your family as legislation comes up. And we have events like today and resources to educate and also empower people with diabetes. We are affiliated with the Diabetes Leadership Council, which is the policy side of this organization to our advocacy. DLC works on anything from the nuts and bolts of the policy, whether that's drafting legislation or helping to educate lawmakers and even staffers on action to take, while DPAC is bringing together the patient community to speak up and speak out on the issues at hand. And both of us partner across the diabetes community with other organizations to build a consensus on action that needs to be taken. Now, part one you see as we head into our session today with Senator Briggs, just a quick look at where Tennessee stands on legislation that it has passed. So you'll see here, this is a list of bills we've been supporting in states, and we're seeing a lot of these talked about and even filed around the country, which is a really good thing. And the next step is to pass them, which earns a check mark in those boxes. So Tennessee is doing very well compared to the dozen or so other states that we visited. And there you'll see here a working box on that insulin copay cap, the briefcase. That's because it's a work in progress. It's something that actually Senator Briggs is going to talk to us today, since that's an effort he's heading. And so without further ado, let's move into that conversation. I'm going to introduce our moderator, which is Ed Hawthorne. He's the vice chair of DPAC's affiliate organization, the Diabetes Leadership Council. He is former chair of the American Diabetes Association and has served on many other boards from the Red Cross to March of Dimes. And he is currently the COO and managing director and partner for CE3 Solutions. Ed has been active in diabetes advocacy for decades, and we're really grateful to have him here with us today. So Ed, I will turn it over to you.
All right, well, thank you, Julie. And for today's panel, we are so pleased and honored to have with us a legislative champion for people with diabetes and other chronic conditions, Senator Richard Briggs. Dr. Richard Briggs was elected to the Tennessee State Senate in 2014, where he represents residents of Knox County in the 7th District. In Nashville, he sits on the Senate Health Committee and is second vice chairman of the Senate State and Local Government Committee. A 1978 graduate of the University of Kentucky College of Medicine, Dr. Richard Briggs practices cardiothoracic surgery at the Tennova Regional Medical Center in North Knoxville. He has also served in the United States Army for over 30 years, having been awarded the Bronze Star for his service in Operation Desert Storm. And Senator Briggs, first of all, thank you for your service.
Thank you.
All right. So everyone has a connection to diabetes in some way, shape, or form. And so I wonder if you could tell us about yours and why you focus on this particular issue.
Well, the diabetes has always been very important to me because as an open heart surgeon, the most common operation I do, probably 80 to 90% of our operations are on people who have developed coronary artery disease. And as we know, diabetes is one of the major risk factors for coronary artery disease. And either as a preventative measure, so people don't have to get on my operating room table, we would like to see good, high quality management of diabetes. And then maybe just as important, after we do the surgery, we like to see very close management of it also. Usually the surgery will really get people's attention that they need to pay attention to their diabetes. But after the surgery, we don't want them to develop recurrent disease in the future because, of course, the surgery doesn't cure their diabetes, doesn't cure their cholesterol, doesn't cure their obesity. But all of those issues are what does contribute to people having recurrent coronary artery problems, recurrent heart attacks in the future. So it is of absolutely one of my very top concerns because we have such a high incidence of obesity, such a high incidence of diabetes in this country that are major, major contributors to heart attacks, strokes, and vascular disease in general.
Great. Now, you sponsored Senate Bill 552 during this year's session, which caps insulin costs at $100 per month. And could you share more about the bill, its impact on people with diabetes, and its status in the legislative process for 2022?
Yes, and that's correct. And as you all know, I don't need to explain this to you. We've seen the cost of insulin just skyrocket in the last couple of years to the point where many people can no longer afford their insulin. And of course, we do have, fortunately, some other very good medications, but insulin for decades, if not close to 100 years, has been the mainstay, particularly in the more difficult to control diabetics. And when people can't afford their medications, their diabetes isn't going to be well controlled. We know that it's one of the leading causes of blindness, in addition to the cardiovascular disease, strokes, and many of the other problems that we see. So what we attempted to address with Senate Bill 522 is really two problems. One, for people that have what we would call the good, well-paying insurance, is that it would cap their copay at $100 for a month's supply of insulin. And for people who don't have the good health insurance, is that the maximum that they would have to pay would still be $100. And what we're trying to do is to make the insulin affordable for our diabetic patients.
Okay, and the status of this process for 2022?
We put the bill on hold this past year, but it'll be reintroduced this year. Of course, like all legislatures and the U.S. Congress, we have to have both a Senate sponsor and a companion bill in the House. Both of those have to be passed. Then it can be signed by the governor to become law. Most of the time, the bills are identical. If they're not identical or one has amendments and then the other, and they're not accepted by the other house, it would have to go to conference. But we only do that a couple of times a year. And I'm really hoping, because there is a lot of interest among everyone of all the members of the Senate, because there's not a single one of us that doesn't have a very high number of constituents that have diabetes that are trying to face some of these escalating costs.
Absolutely. Absolutely. Well, thank you for all the work that you're doing on that bill. And I know we'll talk about this a little bit later, but you have DPAC here and an army of advocates. So if we can ever get ourselves together to help you in any way, you just have to call on us. Yeah. Now, you've also historically co-sponsored bills which would offer patient protection from practices like non-medical switching and fail first or step therapy policies. So could you discuss your perspective on these practices as a healthcare provider and how these bills may help the chronic disease community?
Well, my bills that I've carried in the past on step, a lot of those had to do with cancer treatments. It had to do with the treatment of hypertension and, of course, diabetes also. And what we're trying to do with some of those bills, if we have drugs that we know work, if we have therapies that we know work, rather than starting with therapies that may not work and losing time and letting the disease progress to a more advanced state, is what the bill tries to do, is to allow the clinician to go directly to the medication or the treatment that he or she feels is the most effective in this particular patient, rather than having to go stepwise through therapies that the attending physician may feel aren't effective, and it's just delaying getting to the most therapeutic, treatment, for the particular disease. And that's actually much bigger than even diabetes, but diabetes falls into that same category also.
Mhm. Thank you. Now, as a member of the Senate Health and Welfare Committee, you're working with colleagues from different parties and different areas of the state. Could you speak more broadly to some of the health priorities for the committee, as well as your caucus, and what they might mean for the chronic disease community?
You're absolutely right. Now, Tennessee is one of the most Republican, and I am a Republican, and we're also one of the most conservative states in the country. But one of the things that I've found has been encouraging over the last several years, and this isn't related to diabetes, but it relates to the opioid drug epidemic, particularly in Eastern Tennessee and Appalachia. Of course, we have the drug epidemic all over the country, but in particular in Appalachia, in West Virginia, Eastern Kentucky, East Tennessee, it's really hit hard. And even with this very conservative state, there's been a recognition that we do have health problems, and particularly related to the opiates. And one of my biggest surprises dealt with needle exchange that I carried a few years ago. When it was first discussed, we had another physician, he's not in the Senate now, but we were talking about it, and I said, that'll never get out of committee in our conservative state, is to do a needle exchange. And lo and behold, to my surprise, we have 33 members of the state Senate, and we had a 32-1 vote in favor of it. So, and I think it does mean that when we do have a serious problem and members can be educated to what the problem is, and then they understand the problem, we can get bills passed that maybe 5 or 10 years ago wouldn't have garnered 5 votes, but now they're getting, almost a unanimous vote when we bring them before the entire Senate. And that, as a clinician, that's very, very important and very noteworthy, because we can do that about other diseases.
Yeah, that's quite an accomplishment right there in and of itself. So it's also been well reported that COVID, as well as diabetes, has had a disproportionate impact on certain segments of the population, generally referred to as health inequity. And so how are leaders in Tennessee working to address this for those communities?
And you're absolutely right. With COVID nationwide, some of our minority communities have been more reluctant. There's long historical reasons why they just don't trust the medical establishment as much. One of the things that we've worked on, and I can speak more to my community of Knox County and Knoxville, and in the recent census, we're 480,000 people, so we're pretty close to 500,000 people. But we've really enlisted in our minority communities, we've really enlisted the ministers of churches. We have one lady that was previously in county government who has been one of our biggest advocates in the minority section of town, and we've been very successful, I'd say, in bringing the minority community to the table, having the community leaders, which many times these are the church leaders in the minority community, and with the COVID, and I don't have the data on this, but it would not surprise me is if we have a higher percentage of our minority population in my county that's been vaccinated than I would the rest of the county as a whole. And I think the lesson to be learned from that is that when we really work together, we bring all the participants to the table, is that we can do this more on COVID. We could also do this on diabetes. We could do it on prevention of heart attack. Really diabetes, if you're talking about preventions of stroke, blindness, heart attack, kidney disease, all of those are related to diabetes. So we don't need to necessarily segment that into a heart prevention talk or a blindness prevention talk or a kidney disease talk, because that's where it all converges on the problems of poorly controlled diabetes.
And so in addition to like bringing the communities together, would you also add in there the education and awareness component? Because if you bring it together, it sounds like you brought the community together, you educated them, and as a result, they acted, right? And so is that a message for the broader community?
I think that's a message for the broader community. And I wish we could have done that with other segments of our community. That's the non-minority segment, because, quite frankly, we've really had a very poor, and I'm going to call it like it is, poor public response to the COVID vaccination. And that's reflected in the number of deaths, the number of people that have been sick. But I think there's lessons to learn that if you bring everyone to the table, particularly the community leaders, the trusted community leaders, that we have a good way of approaching the general public with it. Because when they go back to their communities, this is where they live, this is where they work, then we can get the message out and then give them the resources, which we have had with COVID. If we could get those same resources for diabetes, then I think we could really make some headway in trying to get the disease under control.
Thank you. So look, my last question here is, what's the best way for our smart advocates to help you and work with you to engage their representatives? And sometimes we hear that a couple of people writing in can get a lawmaker's attention, and I know there's also a timing issue. So can you help us understand how we best work with you?
I think at the state level, an email campaign can have a bigger impact than maybe if you're trying to write your congressman, just because we're a little bit smaller. Like I think in Tennessee, I have around 220,000 constituents. That's a lot less than a congressman that may have 800,000. But a letter writing campaign through email, and I think email is the best way to contact people rather than what we call the slow mail with a postage stamp, where not necessarily where there's a form letter that someone writes and then everyone just mails that letter in. They sometimes get ignored, but it doesn't have to be a long explanation. It can just be a little paragraph. For instance, right now, one of the newer issues deals with the insulin pumps, which we're trying to get the Medicaid, our Medicaid, we call it TennCare in Tennessee, to try to get them to finance, because they don't do that right now. But I think just a simple letter, it can be a paragraph or two paragraphs that says, my sister who has good insurance has an insulin pump. It's really helped her control her disease. She's doing very well with it. I'm on the Medicaid program. I've got very brittle diabetes. I'm having a lot of trouble no matter what I do controlling it. Would you do what you can to try to get this covered under our Medicaid program? And I think just no more than what I said is where you've made it personal, you've gave a very quick response to it, then those emails do get a lot of attention. And then when we'll have our Diabetes Day on the Hill, and we'll have the advocates such as this organization. And thank you all very much for what you do. Will come up, bring someone that has diabetes, bring someone that has the insulin pump, whatever the particular issue is, bring someone like on Senate Bill 522, bring someone that's having a hard time, because when you start putting a face to a problem, people get it. And I think that is just very, very effective when we're in our legislative session to come up and visit as an organization, come up and visit. Like I say, we have Farmers Day on the Hill, Doctors Day on the Hill, Diabetes Day on the Hill, and schedule it with the people, with your representatives, and bring real people with real problems that can give real examples on what the particular issues are for that year.
Well, thank you so much for the advice, and that's very helpful. And I know that our advocates that are on the line are going to take that advice and guidance to heart. And just wanted to say thank you, Senator Briggs, for all that you're doing and being a champion for people with diabetes. And we really appreciate you devoting some time with us today. And again, thank you. And I will turn it back over to our host, Julie.
Yeah, Senator Briggs, I was just going to also say thank you as well. Putting a face to a problem. I mean, that's what we try to do. That's our mission in advocacy, is to empower our advocates to be that face. So thank you for mentioning TennCare and the Medicaid program and the need to cover devices to help folks manage diabetes and to make it personal, to share our stories when we do that. And I appreciate you making sure the copay cap is again filed this year and worked on. We understand that you need to have a companion in the house, and we would be glad to work with you to make that happen and to have our advocates weigh in via calls to action and emails and even in the Hill Day to make sure that that lawmakers are really understanding the importance, especially as you mentioned, so many of their constituents are impacted by diabetes. And lastly, I just want to say thanks for your work to partner with the minority communities and local churches to bring them into the conversation because everybody has to be involved, especially those who are most impacted by health disparities. So thank you again, really, for your time today and for all those subjects that we talked about. That was a lot of content to cram into our time frame, and we're very impressed that you could do so so succinctly and really make it clear what you're working on and what the House, Senate rather, is working on. So thank you so much.
Hey, good. Thank you.
Thanks. All right, Ed and Senator Briggs, if you guys would turn off your cameras and mute your mics. We will continue here, and you can feel free to stay on or you can drop as needed, but we'll jump right into the next part of our presentation today, which Senator Briggs has set us up very well for. So we will start with Congress, and you'll see here that like every state, Tennessee's got 2 senators elected, and they also have 10 members of their congressional delegation. And if you're not sure, if you're looking at this slide and you're thinking, who is my member of Congress, you can use that link right there at the bottom to help you understand that. But we just want to give you a look at what your congressional makeup looks like. But more than that, we want to talk to you about the caucus. So the Diabetes Caucus is a group of folks that form around a shared concern or interest, that being diabetes, but also their caucuses around a number of subjects. The Diabetes Caucus in Congress is actually the biggest in health, and there are more members who are in that caucus than who are not in the caucus. So that's something we're really proud of. And the idea here is just to get more members to join, which tells us that diabetes is something that they care about, that they want to pay close attention to. And then we remind them of that when bills or asks that we have come up that they can support, and we reach out to those in the caucus. So one of the asks that you can make on our website at any time is to be sure that freshman representatives, so that's anyone who was elected in November of 2020, their first year freshman, is able to join the Diabetes Caucus. So it's a very bipartisan group, which is good because diabetes should not be one side or the other. And for those of you who are in Representative Harshberger's district, if this action is actually open to you, so you can, through our website, click to ask her to join the caucus. It doesn't necessarily mean that any member in the caucus will take certain action, but it's a sign that they're committed to understanding and working on diabetes. And the ask means a whole lot more when it comes from a constituent. So we'd love to have you do that if you are in this district. And now let's move back into the state legislative landscape, which is what today is all about. So Tennessee is one of 38 states where there is a trifecta. That means that the House, the Senate, and the governor's office are all held by members of the same party. And as Senator Briggs pointed out, that is the Republican Party. Republicans have held power in both chambers since 2010, and they currently have a supermajority, which allows them to do a lot on their own. The legislature is part-time, meaning that many members have full-time jobs. The body meets for 90 days over the course of 2 years, and that's typically concentrated in that first half of the year. But legislators are still meeting informally throughout the year when they are out of session, when they're adjourned. So this means that they're having conversations on key issues, but they're not voting on them. So we'll plan to ramp up our state advocacy efforts for our champions to weigh in on as the session begins, and let you know when we have calls to action, as we were just discussing in that last panel. We are going to look to, as we think about passing bills and this process of weighing in and sharing our stories, there are a lot of chances to do that because a bill has a tough time actually becoming a law. As you see, Schoolhouse Rock there on the slide is quick to note in the song that everyone likes to sing. But hundreds of bills are filed each year, and a lot of them don't make it through. So the point of this slide is just to show you it can be an uphill battle. A lot of times, as Senator Briggs was telling us, a bill is filed and it doesn't necessarily move that session. And so you come back and you work at it again. So we have to be patient but persistent and make sure that the issues that we care about are moving through the process so that they can eventually become law. All right, so we're going to change now over to our DPAC Advocacy 101, which is going to give you a look first at our champions. So who are DPAC champions? They're like the National Guard in our diabetes advocacy. They stand ready to take action as needed. As we noted, the diabetes community is really full of passionate people who want to learn more and who want to be involved. These champions are people who join events like today. So those of you with us, they send emails, they tell their stories when opportunities arise. And you'll see on that next slide, we have thousands of folks from all 50 states, and that includes actually many in Tennessee. So we're proud of that. And we'd ask you to sign up and make sure that your friends and family are subscribed as well, so that they can also take action. And you can do that on the website at any time. You can subscribe, you'll get our newsletter, you'll get calls to action. The stronger our numbers are, the more we can accomplish. So we'd really encourage you to tell those close to you about DPAC and to be sure that they're taking action when they can as well. So we have talked about being an advocate and who the champions are, but exactly what are they advocating for? What are those issues? And we've got a panel that's going to describe the what. We have and Stuart Perry, and I'm going to invite them to turn on their cameras as I introduce them today. Both of our panelists are past chairs of the American Diabetes Association. And here in Tennessee, I think it's appropriate to say that these two put the volunteer in volunteer state. So they bring a lot of time and energy into this issue, and we're so grateful for that. They also bring personal experience with diabetes. George has been type 1 for over 40 years and has 3 other family members with diabetes. And Stuart has type 2 diabetes and a long line of diabetes connections in his family also, including a son with type 1. So welcome, George, our CEO, and Stuart, our vice chair. I will let you both take it from here on the what.
Thank you, Julie, and welcome everybody. Thank you for spending part of your afternoon with us. We certainly appreciate it. I'm George Huntley, and Stuart is not.
I'm not George Huntley, and I'm ready to go to the next slide.
Awesome. So let's talk about what's going on in hot topics in diabetes legislation. Stuart, what's a diabetes action plan?
Well, a diabetes action plan is actually it is required in the state of Tennessee that the health department and the Medicaid department give a report every 2 years or so to the legislature on efforts to fight diabetes. What can we do to move the needle in Tennessee on diabetes? Tennessee has such a plan, and I was there and helped get that passed. And it is a strategic plan to fight diabetes. And then we heard the senator talk, I think, George, about copay caps, did we not?
We did. I think he's championing a bill, and this is a piece of legislation that is going across the country, and in fact being talked about at the federal level right now in the Build Back Better plan. But at the state level, over 20 states have looked at this and are passing this from a range of $25 to $100. I think the one in Tennessee, if I understand correctly, is at $100 level that's being looked at today. These are helpful at the state level, but they only impact state level plans. And Stuart, about that as to, who does that really impact in the state of Tennessee?
Well, first of all, Senator Briggs.
Yeah.
Thank you very much for your attention to diabetes. But secondly, the issue with that is copay caps only affect normally the employees' health insurance and those health plans that are governed by the state. That's about 10% of the people in Tennessee. It needs to be federal. But George, as you know, if we can get it passed in enough states, the feds will pay attention. And when Senator Briggs becomes a senator in Washington, he can take that along with him and push to get that done. We're not talking federal today, George, but as you know, they're talking about that at the federal level right now, which would help because the ERISA plans, which is your employer plans, is what's not affected by Tennessee legislation. And when those things get done, then everybody gets it.
Yeah,
but I think, George, when we look at the next thing on this slide, which is emergency insulin, Tennessee has that passed it in 2018, didn't they?
That's correct. And just to clarify, before you would said employees, you're really talking about state employees only,
Correct.
not any employee that's working in the state, but a state employee of the state. That's all that the copay caps would apply to, which is why we need to cover it. We need to cover all populations. And yes, and one of the things that's important here is a little over 1 in 4 of today's attendees have rationed insulin, and nobody should ever ration insulin. Really bad health outcomes happen, and there are ways to help you through that. So if you are having that conversation, if you're having that issue, please reach out. There are ways, there are manufacturer programs or other programs that can help folks in that situation, and nobody should be rationing insulin. Need to say that out loud, but way too many people are. And Tennessee, we've given a lot of these, and that number sadly is consistent across the states that we've been talking to. Then moving to Kevin's law, which Tennessee has passed. If you need a 30-day supply and emergency access, if we all, I'm on insulin, I drop that vial, it's made of glass. If it breaks shatters on the tile floor, I need emergency supply. They're allowed to dispense it to me, and I can continue to keep my therapy.
Rebates. There was just a congressional hearing. It was a Republican congressional hearing. It wasn't bipartisan on this issue right here, George. It just happened, just stopped a little while ago. Representative Comer from Kentucky actually had that, but there were representatives from all across the South that were on it. And they talked about this issue right here. Rebate and discounts pass-throughs. I learned about new discounts, DIR fees. I didn't even know those existed. And other things that happen between PBMs and pharmacies and insurance companies that cost patients money. A rebate, George, is not like a rebate for your car, correct?
Right. That's a nice thing. I buy a car and I get a rebate, but I get the rebate. The problem here is I don't get the rebate. I still pay for it, but I don't get the rebate back. Somebody else is getting the rebate.
And we're going to talk about this on the next slide. But essentially, a rebate is what the pharmaceutical company, let's talk about insulin. The insulin company sends to the PBM every time, George, you buy a vial of insulin. And that rebate can be as high as 70%. Is that not correct?
That's correct. You look at the example right there on the screen. It was of $350, roughly $280 are pieces that are being taken away by the middleman. And that middleman is PBM. So Jacob, go ahead and move us to the next slide, because this really is where it just makes perfect sense, doesn't it, Stuart? Does it make sense to you?
Well, yeah. So this slide makes a lot of sense. So let George and I see if we can interpret it for you. So the first thing you want to do is put your left hand over the left-hand side of the screen as you're looking at it. When you do that, you're looking at the right-hand side of the screen. Anybody ever heard drugs are cheaper in Canada or in Mexico? This is why. Because the consumer is us, the patient. We go to the pharmacy, we take our script, we go to the pharmacy then gives us our insulin. We pay the pharmacy our deductible or copay. We all know in high deductibles plans, that deductible can be thousands of dollars and the copay as well. So if you're still in deductible phase, George, you might pay $1,000 or $300 or $100, whatever it is that your plan is negotiated for that vial of insulin. The manufacturer has sent the vial of insulin to the pharmacy. The pharmacy pays the manufacturer. Now, sometimes over on the right, you've got drug wholesalers where it goes through them and they take a little piece of the pie. That's the way it's supposed to work. That's the way it works every place else in the world. But in the United States of America, a country I love, country I will defend with my life, it doesn't work that way when it comes to the money, does it, George? Now, George here, my good buddy George, who's a plan administrator of a employer health plan for 20 some years, and is also a trained CPA, okay? Certified public accountant. Now, let me say this, George. Try to explain the left-hand side of this screen to me, will you please?
Yeah, it really stands for certified pain in the, but that's a different discussion.
Yeah, that's it.
So you look at the left-hand side of the equation, and it's really about getting access to the marketplace. So the drug company, in order to have the privilege of selling to the consumer, you and I, who are part of a plan, the plan is administrated by that pharmacy benefit manager, and they have a formulary that determines which drugs we as members of that particular plan get access to. So which fast-acting insulin do we get? Which long-acting insulin do we get? Which blood pressure medicine? Which other, SGLT2, which DPP1, DLP1s? What do we get access to? Because there's multiples, but you only typically get one. And what the pharmacy benefit manager is doing is negotiating with the drug companies to say, I'm going to give you access to all my people, but you've got to give me a rebate, a market access fee. And the more money you pay me, the more likely I'm going to give you access to that formulary. The drug company says, sure, I'll be happy to do that. I'm just going to jack up my list price to cover the rebate you're extorting out of me effectively. So the drug company, fine, I'll just keep ratcheting up list price. The PBM is happy because they just keep getting more and more money, and they're keeping a slice of that money. And you see the green line going up to the insurance company or the health plan. They're passing on the bulk of that, honestly, to the insurance company or health plan, but they're keeping a piece. So they have a perverse incentive to put the absolutely highest priced drug on the plan because they're taking a piece of every transaction that happens. So instead of getting the cheaper drug on your plan or getting any of that savings, if you will, passed on to you, they're keeping a bit of it. The balance goes up to the insurance company, where I'm a self-insured employer. My company gets the rebate. Now, what we do in our plan is we pass the rebate on to the participants, my employees, at the cash register. It can be done. It's just not done very frequently. And that's really part of what we're talking about, because without doing that, the consumer's paying $350 for a vial of insulin, and they should be paying, they should be paying for free or $30. But if they were paying what the plan was paying, they'd be paying $70.
So, but none of my insurance premiums go down as a result of this, George.
Well, that's just, fuzzy math, which is what I live for. So in theory, the insurance company is taking all those rebate monies, and they're keeping everybody's premiums down. And, just imagine how much it would have gone up if you hadn't subsidized everyone else with that. But we have the sick, the patients with diabetes, subsidizing the healthy. And that is exactly the opposite of how insurance is actually supposed to work.
So George, this one line here that goes from the PBM to the pharmacy should have an arrow the other way, shouldn't it? Because the pharmacy's also paying the PBM.
Yeah, the pharmacy's paying a PBM, the PBM's paying the the money going back and forth in this is dizzyingly. It just makes your head spin around. But the other thing to remember is they all own each other. So the insurance company owns the PBM, which also owns the pharmacy. You get CVS, you have CVS Caremark, you have Aetna. You've got everybody is together, and it's not like we're together. We're just all taken out of each other's hands.
So George, why don't the insulin companies just share what the rebates are, and then they can lower the price by lowering the rebate?
Because they would lose. The pharmacy benefit manager would throw them out. And as an example, you've got biosimilars coming on the market, and they're not getting access unless they raise the list price and add a rebate. You've got in many plans 10 years ago, the generics and the biosimilars, 90% of those would have been on the formularies, and they would have been on the formularies at the generic level. Today, it's less than half of generic drugs and biosimilars are on the formulary at the generic level, which means patients aren't getting the benefit of these lower cost drugs because the PBM isn't making enough money, so they're not giving them access.
But why doesn't Lilly and Novo and Sanofi just share what they are and discuss it?
Yeah, they're really, one, it's illegal. It's called collusion.
It's illegal.
It's illegal.
The government says they can't do it.
The drug companies cannot speak together and plan out their pricing. That's illegal. So they can't do it. The other reason they couldn't do it or wouldn't do it is if one of the companies were to lower their list price, they would lose the market share because the other company would not.
Okay,
So,
but George, so why don't I just say I don't have insurance and go to the pharmacy and buy it at the net price?
Because the pharmacy is not allowed to sell it to you at net price, because by contract, they have to sell it to you at list price unless you've got access to a formulary that gets you to net price. And very few of those would actually sell it to you at net price unless that plan is designed in that fashion. So if you look at this slide, you can see what's happened to list price over the past 10 years, really 8 years. It's gone up 141%. But the net price is actually dropping, which actually makes sense. There is competition in insulins. You've got at least three major manufacturers. You've got biosimilars coming on the market. Price competition happens when there are multiple players in the game. There are multiple players in the game that literally the net price is almost cut in half. That's substantial. We can argue all day long whether it's enough, but the problem is the patients not getting access to that discount. And so the list price is going through the roof, and that's what makes the headlines. And that's what a copay cap is there to help. We've got to get a copay cap in place where the patient isn't harmed by this gamesmanship that's going on. I know we're running short.
Yeah, I don't care about that. So Julie cannot talk at the end. So George, the list price shown here was $350, and the rebate and the discount is what accounts for the difference between the list price and the net price, correct?
Correct.
Somebody asked they didn't understand what a rebate was. That's what the rebate is, that difference that gets sent back by the manufacturer to the PBM. Now, George, if I don't have insurance and I can't afford the list price, what do I do?
You go to the manufacturer for some patient assistance plans. There may be some other, if you're low income, access to a community health center that may have a 340B program, which is another federal government program that you can get access to. Every manufacturer has something on their website that will help you get access to it. The issue is you shouldn't have to. You should be able, just like anybody in Canada can just walk into the pharmacy and buy it for $25 and it doesn't matter. We shouldn't have to work that hard, especially those of us who are least able to do that. The folks that are uninsured, they don't have the time, they shouldn't have the resources to work through all of those hoops to finally get their drugs. They can do it, and it's far better than rationing and dying. But our job as advocates is to make this go away. And a $35 copay, a $100 copay cap goes a long way to helping patients in that regard. So I do hope the bill that Senator Briggs has proposed gets passed.
But so would rebate reform that allows for the rebates to go back to the patient. So until that happens, George, we've got other issues such as non-medical switching.
Exactly. So
non-medical switching is where you get a letter from your insurance company or your PBM, or you go to the pharmacy and they say, oh, you can't have that insulin anymore. You can't use that strip and meter anymore. You have to use this one. That's non-medical switching, correct?
That's correct. As I said, you get, the formulary is constrained to one drug per class, and it's whatever drug, and by Murphy, it's whatever drug you're not taking. So the insulin that you're on will be switched because the pharmacy benefit manager is going to make an extra $1 per vial, and you as a stable patient have to change your regimen and go to a different drug. And there is only one biosimilar out there right now that is FDA designated as interchangeable. Everything else, it's in the class, but now you've got to switch. You've got to work with your dosing and your physicians. It is so hard as a patient and a person living with diabetes to manage your blood sugars and to get to a stable place. I mean, people rarely tell me I'm stable. It's so hard to get to a stable place. Why in the world would anybody jack with that? It makes no sense whatsoever, except everything here is about the almighty dollar. Over half of the people on this call have experienced this, and it's maddening.
So it's the same thing with step therapy, correct? Same exact scenario. It's all about the dollars.
It's all about the dollars. A little slight twist on this. This is otherwise called fail first. And so in the fail first scenario, you have to start here, fail on this before you get this bigger drug, and fail on this before you get to this drug. And they want you to go to things that make more money for them, to be sure. The issue with fail first, it makes, first and foremost, the physician should prevail. Your doctor's orders should prevail here. The second thing here is, we're not like our parents and grandparents where we started. I've been here for 20 years, where people are staying decades at one job. People are changing their jobs 4 and 5 times in their career. Companies change their insurance plans, going from Aetna to Cigna to Blue Cross, based upon what the best deal is. So every time you change or they change, the step therapy can force you to start all over again. So now you've gone through and failed on these other drugs, and now you have to go back and start over and fail again before you can see. It makes no sense whatsoever, and it's a bigger and bigger issue that we definitely need to address.
So step therapy. So why don't manufacturers have coupons I can use?
Yeah, but you don't want to be using those coupons for step therapy, but yes, they do. And then the question is, do you actually get benefit for it? These copay card accumulator plans, how many, 1/3 of the folks, not quite, have used a copay card today. Stuart, I don't know if you've ever used a copay card. I've used one.
As a matter of fact, George, I used one when I picked up my medications yesterday. Because the pharmacist, blessed pharmacist, the pharmacist looked at me and said, hey, they're wanting $150 for this, and I've got a card, you only have to pay $25, but it doesn't go towards your deductible. I said, well, that's stupid, but I'd still rather pay the $25 and not pay the $125. Why should the insurance company care, George, if you want to write me a check and pay for my medication? It's not right.
They shouldn't care. And I don't want to write you a check, but that's a different discussion. They should not care. You're in your deductible period. You need to go get that drug. It costs $1,000 to get that drug. The plan is getting $1,000 drug paid for by someone else. That's really the whole point here. And that credit is getting stolen from the patient, and the plan is getting the deductibles paid twice effectively, and the patient's left out in the dark because eventually these copay cards run out, and now you have to pay full price and you can't afford it.
And Tennessee has a law about this that just went into effect this year. But at the end of the day, this is part of the patient assistance programs. This is one of the things you can use, as well as the patient assistance programs, where you can get free drugs. You've got to search for them, but you can get these free drugs from companies when you don't have insurance and you can't afford your medications. So George, talk to me about preventative stuff. Where are we on preventative maintenance, preventative for all this stuff of preventing diabetes and complications?
So we all know that diabetes causes complications, right? Uncontrolled diabetes. The whole point here is getting first dollar coverage for your maintenance. So treating your maintenance cost, if you will, to manage diabetes as a preventive care. So in a high deductible health plan, that would allow you to have this as first dollar coverage versus having to meet your $3,000 deductible before any of the copays come into place. So it's great to have a copay cap, but you need a copay cap along with first dollar preventive coverage so that you're not waiting 6 months before you pay your $35 or $100. You're paying $35 or $100 in January when your plan starts, and you're never in a situation where you need to ration. And that's really what this is all about.
So, George, it sounds to me like that all the diabetes organizations ought to get together and publish a document that we can give to Senator Briggs and to the congressional representatives on what needs to happen in health insurance for people with diabetes and their access to health insurance for people with diabetes.
That's a really good idea. The great news is we did. And I'm very pleased that the Diabetes Leadership Council and the Diabetes Patient Advocacy Coalition got together and led a consensus of 12 national diabetes organizations to create a consensus statement on U.S. healthcare reform for people with diabetes. There are very good, solid, tangible ideas in this document, which I urge you to go to the diabetesleadership.org website to download. It's great reading. It will, by the time you're done reading that, you will be really mad because there's a lot of things that we need to do to fix the situation where people with diabetes in the U.S. system. It impacts state level that we've discussed, and there's a lot of things we can do at the federal level.
So, George, what you're saying is people need to go on, download this,
Yep.
and then give it to their state representative, their state senator, their national senator, their congressional representative. They need to give this to them and say, look, this isn't all the answers, but this is a great start. And we need to do these things for me and for people with diabetes, correct?
That's absolutely correct.
Okay. So, George, all I can tell you is all these things can be overwhelming to people. And the issue here is stand up and be counted, right? I mean,
Absolutely.
Does DPAC help people in standing up, being counted?
That is our job. DPAC's role is to empower the voice of the grassroots advocate, empower patients to get your voice amplified out there. And we have ways, and we encourage everybody on this call and everybody watching on Facebook and everybody to forward this. And Jake, if we can move to the next slide, and if it's already shown, there we go. How do you become an advocate? And step one is become a champion. Stuart, what do you think about this step?
Well, let me tell you, a DPAC champion, which I have been since the organization started, is standing up with and be counted and being able to do what you can do. You heard Julie say, we're building the National Guard. It takes a village. Okay. Yeah, it's a one-liner. It's been used just like hope is not a strategy. And it's not. We have to hope that everybody that has diabetes or is affected by diabetes will stand up with the right information and contact regulators, policymakers, insurance companies, all these people to stand up and say, we need your help. You have to be involved. You have to do what's right for people with diabetes. And becoming a DPAC champion is one of the best ways I know to do it. Now, I'm also a champion with JDRF and ADA and everybody else. But DPAC is the one that gets involved in more issues and gives me a better opportunity, George, because we've got to do what? We've got to tell our story. If we don't tell it, George, how in God's name can anybody know what our issues are?
So if you look at this slide before we move off of it, what are you going to see on this slide? If you join DPAC, we have brown bags, and we over lunch, we will give you an in-depth view of a topic so that you will understand and understand what we're talking about. Join us on social media. Join us. We just had a virtual Hill Day. It was really a virtual Hill week, the last week of October. We had 82 people with over 100 meetings with senators and representatives at the federal level. Joining DPAC and it is a way to make an impact. We do get involved at state level as well as federal level issues. And to your earlier point, get involved in all of them. It's like Chicago voting: vote early, vote often. Get your name out of here. And I think the next step shows how to interact through the click of a button. So when we have a what we call a click advocacy engine. All right. And this is one way to interact. That's an easy way to interact. Anybody on this call can do it. Anybody on the Facebook Live can do it. This issue that you're seeing here is support for the No Surprises Act and the year-ending spending bill, which actually got passed. So this stuff works. You will have a letter in there that will talk about the technicalities of the bill, and you'll read it. If you don't like it, then send us a note, and but this is the framing of the issue. In this case, 1 in 6 hospitalizations resulted in an out-of-network bill, and that's true in the U.S. It's one of the leading causes of why we would have healthcare bankruptcies. Now, right below at the very bottom of this graphic is a place where it says show more, tell your story. There's a spot there where you can personalize the message. And it is really important that you do that. And I'm sorry that that graphic doesn't show you the whole page of how to personalize your message. You can write a book in there and tell them about how, whatever this issue is, how that impacted you. You live with diabetes, you have a loved one with diabetes. What's it costing you? What are the hurdles and the hoops that they've had to live with and deal with? And how has that impacted their care and their quality of care? How many hours have you spent on the phone with insurance companies complaining about why you've had to change stuff? That's where you tell your story. You heard Senator Briggs talk about, that's the importance of hearing from the constituents. This is your opportunity. And Stuart, how many of these letters does it take to get somebody's attention? 7. 7 letters is a groundswell. 7 phone calls is a groundswell. 7, it doesn't take 700. It doesn't take 70. It takes 7. A handful of advocates telling their story does make a difference. And so please understand that when you click on these things, you're making a difference. And imagine what happens when everybody on this call does that. It makes an even bigger difference. But honestly, 7 calls makes a difference, especially when you're talking about your representative, your senator in your local area. I encourage everybody to do it. And then we encourage you to call them. Call them, and we will help you with those scenarios. Reaching them out, sending it. Tell all your friends. You're going to get a link from DPAC. So when you sign up, you're going to get a link to issues when they come up. And when they come up, please click on them and please forward that to everybody you know, so that all of your friends can also get involved and we amplify the patient's message. That's what we're here for. We want to amplify the message, allow us to have a voice, and for those voices to be heard.
Next slide, Jacob. Don't forget social media, George.
Social media. We're all social animals. At diabetes.pac, at diabetespac on Facebook, on Twitter, on Instagram, LinkedIn. Follow us. Follow the Diabetes Leadership Council too, but follow DPAC. We're real active out there. Tell your story, share your story, and please, at least 10 times, if you're 10 family and friends, at least 10 people. It makes a difference, and those folks will care about you. Thank you for being here.
Before you close, George, real quick, let me just say thank you for all that you do as the CEO and the voluntary CEO. You don't get paid, you're still CEO. By the way, would you like to be the CEO of my company and not get paid?
No, thank you.
Thank you for all you do. Thank you for your passion. But to everybody out there, besides don't ration your insulin, besides tell your story, besides get involved, it's time to reach up and get mad. At the risk of sounding like an old man, which I am, we're mad as heck and we can't stand this anymore, and throw the TV out the window and get involved. George, I'll let you close, but thank you very much for everything you do. And thank God for DPAC, because they make a difference big time.
Well, thank you, Stuart. Thank you, everybody on this call, watching this program. We appreciate it. We hope you got something out of it, and we hope you will join us in joining this fight. Now is the time to get stuff done. We have an opportunity to help people with diabetes, help ourselves, but it's really not about us. It's about paying it forward to everybody else. Please get involved. It doesn't take that much time. Thank you. Have a great day, and have a happy Thanksgiving.